In this presentation, I will cover the basics associated with assessment theories and models. As I said in Theories and Therapies presentation, I realize this is most likely your least favorite topics, as they can be confusing and challenging. Please make sure you are reading the associated assigned readings. You need to have a solid understanding of this topic, and without the readings, it will be very difficult for you to achieve that. A theory is essentially a way of explaining why something happens. It provides an underlying assumption that directs decisions about client services and treatment. Most standardized assessment tools were based on a theory, and a test was designed to test that theory. We will discuss standardized assessment tools in a different presentation. A model takes the elements of a theory and arranges them into a conceptual structure, or a picture, that describes how the theory works and explains the patterns of relationships that together make up the process. This process has anticipated or predicted outcomes, all of which support the underlying. Although most of us, if not all of us, will not be building assessment tools and going through the research process to ensure they are valid and reliable, it is important that you have a basic understanding of the different types of test construction theories. There are 3 test construction theories. These are classical test theory, generalizability test theory, and item response theory. Classical test theory is based on psychometric properties and is the theory used for the construction of most standardized assessment tools in recreational therapy as well as education. We will discuss standardized assessments as they relate to theory construction on the next slide. The RT standardized assessment tools themselves will be discussed in a different presentation. Generalizability theory uses a limited but representative set of constructs, along with logic, to predict the client's abilities across similar topics. Yes, that sounded confusing. Give me a moment. Generalizability theory tests are norm-referenced, which means these tests measure a sample of skills and compare them to the, quote, norm, with norm referring to the normal population responses or answers. Examples of a generalizability theory test are the GRE, ACT, or SAT. Is it now making any more sense? Maybe. The results from the ACT, SAT, or GRE are compared to the normal responses and is used to predict your knowledge on educational-based subjects. An item response theory test is based on a person's performance on each item within the test. The total score is not as important as being able to complete each task. Confused again? Well, your driver's license test is an example of an item response theory test. Those types of tests are criterion referenced, which means the tests measure all the required components of a task, not simply the sample. In the driver's test, even if you do amazing on every task but fail one, you will fail the whole test. Conversely, if you pass all the components of the test, even if not perfect, you will pass the test. As I indicated on the previous slide, we will be covering standardized assessments on this slide. Most, if not all, of the RT standardized assessment tools available commercially fall under the classical test construction theory. All standardized assessment tools are rigorously tested to ensure they are sound tools. How well the test measures something is expressed by its psychometric properties. Stay with me here. I know this can get overwhelming. Psychometric properties are communicated through statistical significance. Statistical significance is an arbitrary threshold that is usually 5%, meaning that there is a 5% or less chance that the results obtained were due by chance. The reading literature on assessment tools, you are looking for statistical significance written in a language such as P is less than or equal to 0.05. The statistical finding will always be designated with a p-value. Now I realize that many students skim over this section in your literature because it can be very confusing. I am here to help you out. At this stage in your education, you really want to be sure the literature you are using to support your work has value, just like your assessment tools should. When using literature, you are looking to ensure statistical significance by identifying the p-value and making sure it is less than or equal to 5%. Another concept to be aware of when evaluating standardized assessment tools is to pay close attention to the sampling technique used to gain the study participants. Yes, I am still talking about reading the research literature associated with the tool. It is very important that you learn how to interpret the findings and methods used in the literature you review. Sampling simply refers to the process of selecting your study's participants. Non-probability indicates the sampling does not represent the general population, whereas probability sampling is more representative of the general population. Does it make a difference, you say? It can. For example, if you were to do a research study on people's attitude towards doing yoga, and I only interviewed students who already attend a yoga studio, my results would be biased. Of course they have a positive attitude toward yoga. They already attend it. Slightly different, but the same question, I decide to interview members of an all-exclusive gym. Again, I could still get a positive attitude because even if they do not already practice yoga, they value fitness, and that could impact their responses. Always consider the potential bias of the literature, but be realistic. There is no perfect study out there. There is always bias in some fashion. As an RT practitioner, it is your responsibility to determine what is acceptable. When looking into standardized assessment tools and reading literature, a few terms will arise that you will want to be familiar with. First is empirical. Empirical is a fancy way to say, I gathered the information through observation. Another term is data. Data refers to information that can be measured. There are two types of data. Quantitative data refers to numbers, and qualitative data refers to words or quotes. The term operationalized means I have decided and described the concept in such a way that it can be observed and or measured. Although I did not include all of these terms in the assessment techniques presentation, all of them relate to the information provided in that. Understanding validity and reliability is important for the RT professional. We will begin with validity. Validity is the process of measuring a quality of an idea, theory, or concept. Validity is essentially the extent to which the tool meets its intended purpose. Does the tool measure what the tool is supposed to measure? Does the instrument measure what is needed to place participants in the best possible program? Does the instrument yield similar results to what is known to be true about the participant? There are 4 types of validity. You will be expected to have an understanding of the different types of validity. Content validity looks at the topic of the tool and whether or not the tool is actually measuring what it says it will measure. When thinking about content validity, ask yourself, does this tool really measure what it says it's going to measure? Construct validity refers to how well the test elements were operationalized. Remember, I gave you this definition earlier in the presentation. So how were the test elements operationalized so they can be measured? For construct validity, ask, have we selected the most accurate way to measure the content? Criterion-related validity refers to how well one can make predictions about the criterion based on the results. When thinking about criterion-related validity, consider how well one can predict one set of scores from another set of scores measuring the same variable or topic. This question is considered congruent validity if we are testing the same variable within the same time frame. But if we are looking into the future, it is referred to as predictive validity. The last one is clinical validity, which relates to the RT professional's clinical skills and abilities to evaluate results and predict treatment outcomes. In clinical validity, ask yourself how well the results can be used to predict future performance in healthcare. Reliability addresses the quality of performance of a test tool and asks the question, is the tool consistent? When thinking about reliability, the therapist should consider the question, how well is the test written and administered? We will be discussing 3 types of reliability. Reliability is measured by the reliability coefficient. The reliability coefficient is the degree to which the testing tool is able to demonstrate consistency and is communicated using the language coefficient of whatever the reliability is. We will cover that. The first type of reliability we will discuss is called test-retest reliability. This measures the test's stability over time and is common in our profession. It is calculated by taking the scores of a group at one administration and then again at another time. The scores should not change if no changes have occurred in the individual. Test-retest reliability is communicated as the coefficient of stability. The second form of reliability is inter-rater reliability, or sometimes called inter-observer reliability. This was briefly touched upon in the assessment techniques presentation. Inter-rater reliability refers to the ability to have different therapists use the same tool, observe the same situation, and draw the same conclusions. In essence, regardless of who administers the test, the results should be consistent. This requires staff training and strict adherence to a protocol and established rating system. The inter-rater reliability is communicated as the coefficient of inter-rater reliability. The type of equivalent forms reliability will be our last reliability form discussed. This measures whether or not 2 versions of the test are equivalent. To determine equivalent forms reliability, 2 forms of the test are given to the same group of individuals in close succession. The scores are compared to see if they are statistically equivalent. This type of reliability is communicated as the coefficient of equivalence. It is inaccurate to say a tool is reliable or valid. Reliability and validity are stated in degrees or percentages. There are no absolutes. When choosing a tool, the practitioner will want to make the selection based on the targeted population for the tool as well as statistical significance. This will help to increase the validity and reliability of the tool. There is a good chance, but no guarantee, that if a tool has good content, criterion, and construct validity, that it will also have good reliability. There is no guarantee that a tool will have any level of acceptable validity just because it contains outstanding reliability. This relationship is not reciprocal. In general, good validity generally will result in good reliability, but good reliability does not equate to good validity. It is very important for RT professionals to have an understanding of psychometric properties and how to read literature findings associated with assessment tools. When the therapist understands the relationship of validity and reliability, the professional can make an educated decision as to whether or not the tool is good enough to be used to help make treatment-related decisions. On this slide, you will see some factors that can impact the validity and reliability of your assessments. Whether using commercially produced standardized assessment tools or in-house design tools, it is very important to watch out for bias in test construction. This could range from using language above a 5th grade level to terminology that is specific only to a particular region of the country, to having unclear or confusing directions. And some tools may have 100 questions and take a long time to administer. Test fatigue can negatively impact the results. Make sure the tool is appropriate for the cognitive level of the patients. Individuals with learning disabilities or cognitive limitations could struggle to comprehend the directions or even the questions themselves. As I stated earlier, there is no perfect tool. You just want to make sure you are aware of the tool's limitations and are attempting to administer the assessment in a fashion that will yield the highest. The last topic covered in this presentation is correlation coefficient. Correlation is the relationship between two different items. When there is a change in one, there is a predictable change in the other. Positive correlation refers to when the first variable increases, so does the second. Or if the first variable decreases, so does the second. They move together. An example of this would be getting a promotion at work results in more pay and a higher position in the company. Both the income and the career placement has increased. Negative correlation refers to when the first variable increases, the second one decreases. Or, in general, when one moves in one direction, the other will move in the opposite direction. The classic example for negative correlation is weight. If I increase my exercise or energy output, my weight will decrease. In this case, as exercise increases, weight should decrease. In treatment, correlation coefficients can help the therapist to measure the impact of a client's functional ability and/or attitude. Correlation coefficients are expressed in terms of +1 for a perfect positive correlation or -1 for a perfect negative correlation. I realize the material in this presentation is challenging and often confusing. Please make sure you are reading the course-related materials to help you gain a more in-depth understanding of the topics. My hope here was to shed some light on those tough concepts in an attempt to help you better understand the research you are reading. As an RT professional, you will need to make decisions regarding assessment tools, and it is important you make educated decisions on how to proceed with your practice.